My name is Dr. Natalia Khomko and I'm an obstetrician from Obstetrics and Gynecology Consulting Group. I will be talking to you about screening and prevention of preeclampsia. In my presentation, I will cover definition of preeclampsia, prevalence and implications of preeclampsia, main therapeutic interventions available for prevention of preeclampsia, which are aspirin and calcium, efficacy of aspirin and calcium, and also screening for preeclampsia, which involves clinical screening and first-trimester combined screening. So what is preeclampsia and why is it important? So preeclampsia is a multi-system disorder with new onset of hypertension after 20 weeks of pregnancy, accompanied by one or more signs of the following organ involvement. Renal involvement, including proteinuria, oliguria, and raised serum creatinine. Liver involvement, including raised transaminases and right upper quadrant epigastric pain. Hematological involvement, including thrombocytopenia, hemolysis, and DIC. Neurological involvement, including eclampsia, stroke, headaches, visual disturbances, and hyperreflexia with clonus, pulmonary edema, and fetal growth restriction. Preeclampsia affects 2 to 5% of pregnancies, and 1/3 of these pregnancies will need delivery at less than 37 weeks. Early onset preeclampsia, which is defined as needing delivery at less than 34 weeks, occurs in 0.3% of pregnancies. Preeclampsia is responsible for 25% of stillbirths and neonatal deaths, 15% of fetal growth restriction, and 15% of preterm births. Worldwide, preeclampsia causes more than 70,000 maternal deaths and more than 500,000 of infant deaths per year. It is also associated with long-term health risks for mothers and offspring. And the only cure for preeclampsia is delivery. Therefore, prevention can have significant impact on maternal and infant health. There are two main agents available for prevention of preeclampsia: aspirin and calcium. Aspirin is generally given at a dose of 150 mg with dinner from 12 to 36 weeks of pregnancy. It should ideally be started at less than 16 weeks and definitely at less than 20 weeks. Calcium is generally given at a dose of 1,200 mg for women with low dietary calcium intake. So the efficacy of aspirin has been demonstrated in a recent 2019 meta-analysis involving more than 40,000 women from 74 different trials. This meta-analysis demonstrated an 18% reduction in preeclampsia with a number needed to treat of 61. This means that 61 women will need to be treated with aspirin for one case of preeclampsia to be prevented. The meta-analysis also showed a 15% reduction in fetal and neonatal deaths, a 9% reduction in preterm births, and 16% reduction in small for gestational age. It also showed 10% decrease in composite serious adverse maternal and neonatal outcomes, which includes all of the above complications. The meta-analysis showed a small 6% increase in the risk of postpartum hemorrhage, and an increase in placental abruption, which was not statistically significant. So the authors concluded that aspirin improves outcomes and appears to be safe. And being able to identify women most likely to benefit will improve targeting the treatment. Now on to calcium. So the efficacy of calcium has also been demonstrated in a recent systematic review. This involved more than 18,000 women from 27 different trials. 2/3 of these trials were conducted in areas with low calcium intake. Just over 1,000 mg of calcium daily was used from mid-pregnancy to delivery. The review demonstrated 55% reduction in preeclampsia, 45% reduction in hypertension, and 24% reduction in preterm births. And this reduction in risk was greatest for women that had low dietary calcium intake and women that were at high risk of preeclampsia. Authors felt that treatment effect may be overestimated due to small study effects and the risk of bias. However, women with low dietary calcium who are at risk of preeclampsia may benefit from calcium supplementation. So, can we determine which women are at an increased risk of preeclampsia and will benefit from aspirin and calcium? We can do that through screening in early pregnancy. And there are two main methods available for screening. Firstly, there is clinical screening, which is based on risk factors. This is the screening approach recommended for all women, and it is the most common approach used in Australia. And secondly, there is first trimester combined preeclampsia screening, which is based on Fetal Medicine Foundation algorithm, and it is available in some centres in Australia as well. This algorithm includes maternal risk factors, measurement of blood pressure, a blood test measuring placental growth factor, and a uterine artery Doppler measurement from an ultrasound. Of note, Victorian Clinical Genetics Service offers early onset preeclampsia screening without using the uterine artery Doppler. So now specifically talking about clinical screening. So as mentioned, this screening is recommended for all women by major Australian and international hypertension and pregnancy guidelines. And the detection rate of this screening method differs between, or ranges between 34 and 41%, being slightly higher for early onset preeclampsia. Aspirin is recommended for women with any of the strong risk factors, which are hypertensive disease during previous pregnancy, chronic hypertension, chronic kidney disease, SLE or antiphospholipid syndrome, and type 1 or type 2 diabetes. Aspirin is also recommended for women with more than one moderate risk factor, which are nulliparity, advanced maternal age of more than 40 years, BMI of more than 35, with some guidelines using BMI more than 30, interpregnancy interval of more than 10 years, family history of preeclampsia, multiple pregnancy, and IVF also being included by some guidelines. So now on to first trimester combined preeclampsia screening. The performance of this screening was examined in an ASPRA trial, which was a trial involving nearly 27,000 singleton pregnancies. The detection rate of this algorithm was shown to be superior to clinical screening, especially for preterm preeclampsia. There was a detection rate of 76.7% of preterm preeclampsia, which compares to only 39% using clinical risk factors, and a detection rate of 43% for term preeclampsia, which compares to 34% using clinical risk factors. Aspirin was shown to be more effective for prevention of preterm preeclampsia specifically, with 62% reduction of preterm preeclampsia, which increased up to 75% reduction if compliance was higher, up to 90%. And as mentioned earlier in my presentation, there was an 18% reduction for all preeclampsia shown with the use of aspirin from the meta-analysis. And once again, the Victorian Clinical Genetics preeclampsia screening algorithm involves maternal risk factors, blood pressure measurement, a blood test, and is not requiring an ultrasound measuring of uterine artery Doppler. And the detection rate of this algorithm is 75%, which is comparable to the detection rate from the ASPRA trial. So in summary, preeclampsia is a multi-system disorder with significant maternal and neonatal morbidity and mortality. Aspirin is effective for prevention of preeclampsia, especially preterm preeclampsia. Calcium is effective for prevention of preeclampsia for women with low calcium diet. Screening can identify women who can benefit from calcium and aspirin. All women should be screened for preeclampsia using clinical risk factors. And first trimester combined preeclampsia screening is superior to clinical screening, especially for detection of preterm preeclampsia, and can be considered if available. Thank you for your time and in listening to me on screening and prevention of preeclampsia. Hopefully you have found this useful and will be able to implement this into your clinical practice.